Hello and welcome to OncLive News Network. I'm Tara Peterson. Today we have a special program focusing on the topic of metastatic colorectal cancer. To gain insight for this multi-part series, OncLive sat down with Dr. Gabriela Kiorian from the Fred Hutchinson Cancer Institute and Dr. Tanya Spikai Saab from the Ohio State University. There is variation across practices regarding the choice between FOLFOX and FOLFIRI in patients with a KRAS mutation. In this next clip, Dr. Kiorian provides her perspective on this important first-line decision.
In general, if the patient has a mutation in KRAS, we offer them treatment with chemotherapy plus an anti-angiogenic agent, typically bevacizumab in first line. And certain studies suggest that the combination of FOLFIRI with bevacizumab may be slightly better than the FOLFOX with bevacizumab, even if statistical significance has not been reached. Numerically, overall survival was about 33 months with FOLFIRI bevacizumab versus 28 months with FOLFOX bevacizumab, suggesting that maybe when we add an anti-angiogenic, we're better off using FOLFIRI as a backbone. So in my personal practice, I've been using FOLFIRI with bevacizumab a lot lately, unless I enroll a patient in a clinical trial, which is always my favorite option. So again, we're talking about the KRAS mutated patients. If a patient has the mutation and we're offering him or her FOLFIRI with bevacizumab first, naturally the second line would be a FOLFOX type regimen. And oftentimes we would be continuing the bevacizumab in second line, especially if we're using it with FOLFOX because we gave FOLFIRI first. And there is evidence to document, an overall survivorship benefit of about 1.4 months if we continue with bevacizumab. Now, if we start the other way around with FOLFOX and bevacizumab, naturally we'll be doing the reverse, the FOLFIRI second. It's, again, not so much my practice to use FOLFOX first, and I know every institution is different. At the national level, at some point, 80% of the physicians in the United States were using bevacizumab with FOLFOX, not with FOLFIRI. That practice may have changed lately after we had the evidence showing the survival difference. Having said that, again, if we have a KRAS mutation up front and we are using anti-angiogenic therapies first line, we continue on maintaining the anti-angiogenic therapy in second line.
Among the treatment decisions that need to be made are questions regarding maintenance therapy. We asked our experts to shed some light on the value of allowing patients a break from their treatments.
Oftentimes with FOLFOX, the 5-FU oxaliplatin regimen, it is a neuropathy that becomes very cumbersome. And we know that neuropathy can be long-standing. And therefore, oftentimes after 4 up to 6 months of induction chemotherapy, if the patient is doing well, if the patient's cancer is stable or responding to treatment, we talk about a maintenance, a simplified regimen. And oftentimes we will use a 5-FU derivative, which is called capecitabine or Xeloda. It's a 5-fluorouracil prodrug, which becomes 5-FU inside the patient's tumor, in combination with bevacizumab, the anti-angiogenic, which the patient has had all along, in combination with their FOLFOX. So we will not continue the whole FOLFOX and damage the nerve even further. We will do a maintenance capecitabine with Avastin. And we have a lot of evidence that maintenance capecitabine with Avastin is beneficial in protecting the patient's cancer to recur. And we can definitely reinstitute a full course chemotherapy at the time of progression. In addition, if we are using FOLFIRI with bevacizumab, irinotecan oftentimes causes a lot of GI toxicity with nausea, vomiting, diarrhea, and cramping, furthermore causing long-term side effects. And similarly, after 4 to 6 months, we prefer to do a maintenance Xeloda with Avastin for that purpose. Nevertheless, there are patients that are not on Avastin first line. What is the evidence of using other targeted therapies in maintenance? And interestingly, for patients that have KRAS wild-type status, colorectal cancer, who are previously treated in first line with FOLFOX or FOLFIRI with Erbitux, we now finally have evidence from international clinical trials that using Xeloda, capecitabine maintenance with cetuximab, is beneficial as well. So this is very encouraging that we have actually easier regimens for our patients to use, part of maintenance. And I wish we had the same maintenance strategy for other tumors, but colorectal cancer has been one of the best studied in GI cancers.
One of the things we always think about, and our patients always challenge us with, is, Doc, when am I going to get a break? Because especially now that, and thankfully we have all these options, patients are living an average of 3 years, 3.5 years. Some patients have been with me for 7, 8, or 9 years with widely metastatic disease. So these patients are living a long time, which is fantastic. And it's important to preserve a lot of quality to their lives along with the quantity. And you know, patients do get tired on chemo. They do get tired. It's a lot on them. It's every 2 weeks, and some regimens are every week. So they're coming to the clinic all the time. They're coming to the chemo suite. And so the main question is there a time where you could consider a break, or if not a break, at least what we call the concept of maintenance therapy? But for all purposes, we know that most patients in the United States get treated with bevacizumab, with either FOLFOX or FOLFIRI, most of them on FOLFOX, but a growing number on FOLFIRI. We know from studies that were performed with oxaliplatin many years ago, Optimox 1 and Optimox 2 with FOLFOX, that essentially you could give patients 3 months of oxaliplatin, and then after 3 months of oxaliplatin you can go on 5-FU and still maintain the survival advantages with less toxicities. There's also another study with FOLFIRI from the GISCAD, an Italian group, that looked at intermittent FOLFIRI, 2 months on, 2 months off, 2 months off, 2 months off, and compared that to continuous FOLFIRI, and they found no difference between the two in terms of outcomes. Then we have a number of studies that came later in the last couple of years, 2-3 years, COIN and others, that looked at intermittent strategies with FOLFOX. And they all show the same, that we do not lose value from essentially giving patients breaks. In practical terms, that means that after 3 to 4 months of therapy with either FOLFOX or FOLFIRI, you could definitely drop the irinotecan or the oxaliplatin and continue with either 5-FU or capecitabine and bevacizumab as a maintenance strategy. So there's data for 5-FU, there is no data for capecitabine.
With so much hinging on finding targetable biomarkers in colorectal cancer, we asked Dr. Saab to discuss some of the important research underway. We asked Dr. Kiorian to share some of her key recommendations for improving care.
We have then this BRAF subgroup patients, and we have a number of studies that have emerged that suggest that by targeting the RAF pathway and the MEK pathway, or the MEK-RAF and then EGFR, that we do see in some patients some significant responses. I think that's the other aspect of colon cancer that is seeing a lot of developments. Phase 3 studies, international studies, are actually targeting specifically these groups of patients. One of the most interesting targets that had been underrated in colon cancer for the longest time is HER2. So HER2 now is up front, along with PD-1, I think, those two, and then BRAF following behind. HER2 is a target that seems to be incredibly promising. And the Heracles study suggested preliminarily that we do see these very strong responses, very deep responses, and very prolonged responses with dual targeted strategies in HER2 overexpressing tumors. And I think that a number of studies are following, focusing specifically on that subgroup of patients. And it's not insignificant. It's at least 7% of the patients with metastatic colorectal cancer. But here's the thing. If you actually start looking at beyond just HER2 overexpression, you include ERBB2 amplification and other permutations of HER2, you may expand this to 10, 12, or even 15% of the patients with metastatic colorectal cancer that may be eligible to some a HER2 form of therapy. So this is a significant chunk of patients that actually may be eligible for this. So that's another, and I think I would call this one of the hottest, along with PD-1, one of the other hot areas in colorectal cancer, just followed close by the BRAF, and then behind that, all these other mutations that are emerging.
In my opinion, the multidisciplinary care is absolutely key because we can transform people that have a 3-year survivorship and a death sentence into potential long-term survivors. And we do want more and more of our patients to be those long-term survivors if they have multidisciplinary approaches, radiation, surgery, ablation, embolization, used very judiciously. We also want to be sure we are not causing more damage than good when we use our chemotherapy treatments. I see lots of patients in my practice coming for second or third opinions who have had chemotherapy nonstop for years and years and years. We need to know and spread the message that maintenance therapy is now a gold standard after a short period of induction, such that the quality of life as well as quantity of life is preserved. I also want to relay the message that molecular profiling is very precious. And it's true that many of our patients may not benefit from it yet, but we come up with new targets and new platforms of therapy that benefit select mutations every 6 months, every year. And it's very valuable for our patients to have the agenda in front of their eyes. What are my options? What's my first line, my second line? What comes next? Patients are very reassured to know that we have a plan. And I think the more we know about the tumor, the more reassuring and the more straightforward the course of the treatment will be.
That's all for today's program on metastatic colorectal cancer. You can see more videos like this right here on OncLive.com. Thank you for watching OncLive News Network. I'm Tara Peterson.